I love it. Hello, everyone, and welcome. I see we still have some folks joining us today. Thank you, everyone, for joining. As we get started and as we have folks that are trickling into the room, we'd love to know who's with us today. So please feel free to hop into the chat and introduce yourself, name, title, and organization. We'd love to know who we have here. You're also welcome throughout the session to drop in any questions that you might have or comments for the speakers. We'll have a dedicated section of time at the end of the session to address any of those questions, but just so we can kind of filter through them throughout the session as well, feel free. So today's webinar is a part of AHA's ongoing leadership dialogue focused on advancing workforce safety as well as patient safety in partnership with Laerdal Medical. I'm pleased to introduce our host for today, Elisa Arespacochaga, Group Vice President of Clinical Affairs and Workforce here at the American Hospital Association. And with that in mind, I will hand it over to you, Elisa.
Thanks so much. Welcome, everybody. And I see some familiar names popping up in the chat. So welcome, folks I know. Welcome, folks I haven't met yet. This should be a really fascinating discussion. I will say, in the work that I do with clinical affairs and workforce, addressing workplace violence is one of the things my team works on. But even more broadly, we really feel the key to supporting the workforce is creating a safe environment. And that doesn't happen without physical safety, psychological safety, resilience, and well-being. You have to have all of those together. And those are things that I get to work with a fabulous team across the association doing that work. Our work is housed in the under the initiative name Hospitals Against Violence, and hopefully one of my colleagues will pop that website in the chat so that you can find it. Thank you, Ben. And we have all of our resources there. It really is an initiative that offers resources to support work to address workplace violence. Our broader workforce and behavioral health teams are also very involved in this work and are in fact focusing on this issue of de-escalation. As many of you probably know, behavioral health is really where some of this work grew up. And so really, how can we bring those resources to the field? This leadership dialogue, like the ones that came before it and the ones that will follow it, is about real world solutions. So really excited to have both Holly and Brian here to share not only the work that they've done, but the practical implications of what that work has been like. And we'll have them share their work, and then we'll have a little bit of a dialogue. Now, the other piece that I want to sort of double click on here is that we know there isn't one solution to address workplace violence. If there were, we'd all, have that solution, and that would be how we would do it. It's a layered set of solutions. They have different organizations have different needs, different nuances, but it also is having a number of different things in place that work together, that are, some incorporate different skill sets, different people in the organization. But this is one piece that I really think changes the conversation a little bit. And Holly will certainly tell us about the work at Bingham and how they've used this. So today really is about learning from your peers and your colleagues. And so I hope you ask a lot of questions and look forward to the dialogue. So with that, let me introduce, starting with Holly Davis, who serves as Chief Nursing Officer at Bingham Memorial, a legacy community hospital with a diverse clinical workforce spanning long-tenured staff and new grads. And under her leadership, they've really expanded their simulation capabilities to address first obstetric emergencies, respiratory distress, oh my goodness, words, sorry, and staff's safety drills through different approaches, both strategic investments and some philanthropic support. But Holly really led the integration of using Laerdal's de-escalation simulation training to help support the workforce. So really excited to hear about that from Holly in a moment. Second, we also have Brian Bjoern, who's a physician and patient safety manager at Laerdal Medical. He did his training at the University of Copenhagen, Faculty of Health and Medical Sciences, and trained at Copenhagen University Hospital. He's an internationally recognized expert in patient safety, and his work at Laerdal has focused on applying simulation to patient safety and quality improvement challenges. I love that you do this. The doing is so important for so many people to really understand the connections. So, sorry, my own editorial, but he works with customers and partners in the industry to really understand how simulation addresses patient outcomes and organizational performance. So with that, I'm going to turn it over to Holly to give you sort of the maybe 20,000-foot view of what this looks like in practice, what she was able to do in terms of bringing in simulation training to address de-escalation and what that has done and the journey her organization has been on. So Holly, with that, I'm going to turn it over to you.
Yes, thank you very much. It's an honor to be here and talk about what we've done here at Bingham. And we have a simulation lab that's newer to our hospital. We installed that a few years ago with a grant from a philanthropic association in Washington State. And we're able to hire a sim lab coordinator, have a great facility, and really start to learn more about simulation and use that to do things that happen in a community, low volume, high risk. And then it was interesting when we were approached with workplace violence and using our sim lab for that type of a project. At first, I wasn't quite sure how that would work because I'm so used to clinical objective training, multi-agency emergency training, and other uses of simulation. And we love simulation here because, as you know, we work with adults, and adult learners are very impatient, have different ways of learning. Some learn by doing, some learn by practice, some learn by seeing others do it, some learn by video. It's just a lot of different types of adult learners that you work with in a hospital setting. And so simulation has been great, a safe place for staff to learn. And as we put together this workplace simulation training, we used a lot, of course, the same principles. We knew that we'd be practicing something, but it was hard for me initially to understand what the objectives would be, and especially how we would measure success of the training. And it was also important to me as we decided who to invite to our first workplace de-escalation simulation training. I wanted to be really mindful that I invited the right people to that training, especially since we were testing it out for the first time. And we were able to bring together different layers in our organization. It was really important to me that we bring our house supervisors there, a few of our hospitalists, a few housekeepers, a few of course, all of our administrative team, because a lot of times in the past, we focused most of our simulation training on core staff, ICU nurses, ER nurses, med-surg nurses, OR, but we haven't focused on leadership simulation training. And it was really important to me because I don't think a lot of leaders understand what the workforce is dealing with on a day-to-day. And I don't think they understand what the psychological burden is to that and how skilled you have to be as a clinician to handle any situation. So it's not just about making sure you're giving the right medicine to the right patient, but you have to be so self-aware, and you get thrown into situations that sometimes are beyond your control. And I wanted the leaders to feel that. And it was interesting because we go into this workplace de-escalation training. They brought a team of 3, and we had small workshops throughout the day. And that team of 3, they had a police officer from Memphis who does the de-escalation training for the Memphis Police and other police organizations. They had an RN who is skilled in simulation training and understands objectives and simulation training. And then they had a videographer who captured pre and post data of each workshop simulation. And again, like I was like, how are they going to measure this? How are they going to know if we got better? Because when you're talking out things, you're not, it's a little bit harder to measure. They actually had 12 pre-objectives, and I didn't view any of the pre-objectives or post-objectives. I just let them measure the data. And so they had these 12 pre-objectives to the simulation training. And then they measured those to see what our team got better at in each workshop. And they even broke it down by each attendee, like what their initial, because they did a pre-simulation, then they trained us, and then they did a post-simulation, a lot like you would do in any other clinical types of simulation. And it was fascinating to see as an observer what staff were really good at. Of course, the house supervisors are really good at a lot of things because they do this in practice, but what they weren't good on was also interesting because they wanted to go alone to handle this patient and they should never go alone. And so that was really interesting to see that my team was going alone to handle the angry husband in the waiting room, and they should never have done that. And then it was also interesting to see, once they broke from the first simulation and discussed and learned what they did on the second one. But it was interesting to see that they're like, well, you could take anyone with you. You don't have to take someone else trained. You just take someone with you. Or, and then some other things that some of the nurses or leaders would do is get in a dangerous physical space situation and to be coached on that. But overall, I was so happy with how the simulation was ran. I was happy with the objectives that they set out, how they measured those objectives, the final report that they sent back, and then really we just had great feedback from everyone who attended. And it was eye-opening for leaders, when they asked for a volunteer on the first exercise, not a single leader, executive or administrator volunteered to go into that room first. And that's just really telling, like they don't know exactly how to handle the situation. And so that leadership training for me was like, that is a weakness we have and something we need to consider when we're working in workplace violence, because our administrators and our executives, they make the decisions on where our money is spent. And if they don't really understand like what the staff deals with and how many tools they have to handle even just simple de-escalation, then they're not going to fund us correctly. And so it's just really important to have those things in place.
Thank you so much, Holly, for that overview. I think I heard a lot of things that I want to, ask you about, and I know we'll have a more Q&A discussion. But let me ask you about a couple of things that you mentioned that I really want to double click on. I love the fact that some of the first people you brought in the room were leaders, because as a nursing leader, you've walked that walk. You've been in that. You've walked into that room and gone, "Oh no, what did I just walk into?"
Yeah.
But to bring the entire team into understanding in a safe way what that feels like and what that is like is I think just wonderful. The other thing I wanted to ask you about was thinking about some of the work that you were doing to bring this. I like that you went interdisciplinary very quickly. Like you said, you know what, this is going to affect our nurses, but it's going to affect our housekeepers. Let's make sure we have that breadth available. What made you sort of aim for some of those as someone who's, coming from that clinical simulation training, you're interdisciplinary, certainly, but clinicians, what made you think, oh, well, we need to get everybody in the room here?
I think because we are small and on any given shift, you have nurses so tied up with caring for patients. Sometimes it's a risk to even pull a nurse away from caring for patients to go and de-escalate a situation in ICU waiting room, for example. And so thinking more broadly about different people that we have within our walls on any given shift was really important. And then also just different talents. I don't want people to avoid those situations. Now, of course, you don't want to walk into a dangerous situation, but I want them to avoid it because they don't even know what to do or to even know how to support someone. And so that was just really important to us.
Absolutely. I love
It's
that.
something we've identified also on our workplace violence risk analysis. And because workplace violence, it's not just a patient, it can be a staff member, it could be other people. And so in our workplace violence evaluation, which most of these hospitals I'm sure do as it's required through DNV or Joint Commission, we just knew that it had to be multidisciplinary based on that evaluation.
Yeah, absolutely. Well, I love that you used a tool that I don't think most people think of outside of the clinical, using it for clinical applications to improve clinical skills, but it improves skills. So it's a safe way to use that for this. I know we're going to have a little bit more Q&A discussion in a minute, but let me bring Brian on to talk a little bit about his national perspective on doing this work with organizations. I know you spend a lot of your time helping organizations like Holly's set up simulation and specifically start to look at who needs to be involved in de-escalation, who needs to be trained, how often do you train them, all of these questions that come up every time you talk about this issue. So let me have you talk a little bit about some of the barriers you're seeing as hospitals start to do this work, and then some of the solutions you've come up with, and then the three of us will have a bit of a discussion about some of the details.
Thank you. I thought I would start by just sharing a little bit about Laerdal Medical for those on the call who might not know us. So Laerdal Medical is a global leader in simulation and immersive training products and services. We've been doing what we do since the 1960s with a focus on time-critical emergencies and life-saving interventions. Our mission is helping save lives, and we have a specific goal of helping save 1 million lives every year globally by 2030. And we do that by partnering with organizations, including hospitals like Bingham Memorial. So what I'm going to share is some of the barriers that we hear from hospitals as we engage in these conversations about how we can best help them build simulation programs in some form. I'm going to kind of divide it into three main buckets. One being more operational, general barriers. The second being how we balance creating realistic, immersive scenarios with keeping everybody psychologically safe. And then thirdly, how do we go beyond just the individual learning in this simulation and really make sure that we get organizational learning. I'm also going to apologize in advance. I'm recovering from a cold, so I might have a coughing fit midway. I'll try to go up mic for that. But starting off with some of the operational challenges and barriers, and Holly already spoke about some of these. It's not going to surprise anyone that cost is something that we hear about quite frequently. Some of the equipment needed to run good simulations can be expensive, so that is a barrier for a lot of hospitals. Many places are, relying on grant funding or go through multiple rounds of putting in capital requests before they get to a point where they're able to run simulations. And what we, I think, more surprisingly run into quite frequently is hospitals that haven't realized that they also need someone who actually can use this equipment. So it's great to buy a simulator, but you need a technician who can help you maintain and repair it, and you need an educator who can write good educational content for the simulator and facilitate your simulation. Space is obviously also a constraint. No hospital I have ever been to has said we have plenty of space, so I'll take a corner. And finally, staff hesitation, maybe even reluctance if you're bringing simulation in for the first time is something to really consider, because it can be uncomfortable. And we're going to talk a little bit about psychological safety, but it's really important to address that and take that serious up front. And some of the ways that we address these barriers, if you call us up and say, hey, I got grant funding, I'd like to buy the top of the line simulator, we're not just going to sell that to you. We're actually going to have a conversation with you about what are the educational needs you're trying to meet here, what are the organizational needs, to make sure that you're actually getting most out of your money. Maybe you are buying a midline simulator instead, so you can afford some other equipment that is needed. And finally, we're going to talk a little bit about that. We developed a managed services solution so that if you're not ready for whatever of these reasons one of these barriers is in the way, we can actually come in on simulations on your behalf. We do it in places like Bingham Memorial, where we supplemented what they already do themselves. We do it at other places where we're the only simulation component the hospital has. And it really is about making sure that we meet the hospitals where they are. When it comes to that second bucket of barriers, more around psychological safety and balancing that with having realistic and immersive scenarios, this is something that it's not unique to de-escalation simulation, but it is obviously very important for de-escalation training, because when you're de-escalating someone, you're not only managing your own emotions, you're managing someone else's emotions too. And to be able to train that, you need psychological safety. So we kind of think of this as creating a bubble around the simulation. And whatever happens within this bubble, it's a safe and sacred space. No one speaks about what happens in here once they get out of the simulation. I don't want to hear down in the cafeteria next week that I did so poorly in the simulation, because I clearly need to go back to the simulation. But now I heard from from someone who shouldn't know that I didn't do well. That might not do that. So it's really about making sure that create that space where it's okay to not have all the answers. It's okay to make mistakes. It is it is okay to be vulnerable, because it is all about our shared learning as a team. So that is really, really important. And if you're embarking on this journey yourself, I would definitely recommend engaging with a subject matter expert, someone who's used to de-escalating in their day job. So it's not just a theoretical experience for them, but they have gone through that, having to manage their own emotions while they're managing someone else. We also recommend, as a good practice, that hospitals doing this have a way for the staff to kind of tap out of this if they already know if they've been in situations before that where this could be triggering for them to go into this kind of simulation, and to have HR readily available when running these types of simulations is just good practice. Then when it comes to the third bucket, is really about how do we create some organizational learning. I would argue that a well-run simulation, a well-thought-out simulation, everybody who's in that simulation is going to learn something. But how do we take it to the next step to make sure that there's actually some organizational learning? And that's what we try to do by capturing all the data points that we do during the simulation and turn that into what we call a progress report, where we tell hospital, what they did well, where there's some room for improvement, and where there might even be some really gaps. And it is certainly, as Holly talked about, it's a challenge with something like de-escalation training, where there's a lot of soft skills involved. So how do you measure body language? Well, you do that by spending some time thinking about what are observable behaviors, so that you actually capture. So you don't just tell Brian your body language sucked. You have to be specific. Like you crossed your arms, you rolled your eyes. So all those for every concept, we really go through the steps of defining and giving operational definitions of observable behaviors, so that we can actually capture that and deliver it back to hospitals. And as you said, Elisa, this has to fit into the broader initiative you might have around workforce violence prevention. This is not a one-off, and then you're good. It has to fit in with your physical space planning, other activities, and I think really think creative about how you can create opportunities for everybody to participate in these types of trainings. As they did at Bingham Memorial, this is not just for the frontline clinical staff. It's also for it can be for your front desk staff. It could be for housekeeping, for example. Anyone could run into a patient, a visitor, or for that matter, a colleague who needs to be de-escalated.
Absolutely. I love the fact that one of the options here is for some smaller hospitals that may not have the staff. Obviously, bigger ones that have a full team doing education might have you come in and do a little bit, but really the ability to scale that to what the organization needs. And I particularly want to double click on the idea of this is the place to make mistakes. And I think that may be something that resonates a little easier with clinicians, because Skills Lab is something you do, right? It's something you participate in. You go practice, you do that first IV on, one of your colleagues to make sure you are never doing that on a patient. And when they ask you, is this the first time you've ever put in an IV? You can say truthfully, no, it is not. But looking at ways to bring that use of simulation, which is, not uncommon in the clinical space to really start to role play some of these dialogues and conversations, I think is of incredible value. All right, well, let's have a little bit of a discussion. I have many questions for both of you. I'm not sure. There we go. Thank you, Jason, for putting all three of us up here. I'm going to start with maybe the unintended consequences, if you would, but some of the benefits that you've seen, Holly, in terms of how the use of simulation in your training, specifically to de-escalation, impacted your team, your leadership. What are some of the things that maybe you expected and some that maybe you didn't?
Yes, well, to Brian's discussion about a safe place, we had a safe word. And so anytime during the simulation was very intense. It was very realistic. And, he's a very skilled trainer, and it was very real. And so there was an emotional, like everyone spoke about, that was so real. I felt like that was really happening. I felt like I couldn't think. I didn't quite know what to say. I didn't realize that I let him block the door. I didn't realize he was holding scissors. I mean, all of these things had occurred. So really that high level of self-reflection and self-awareness. And that was the one thing that we measured a huge improvement on, was the self-awareness. But the realistic simulation was a really good thing for my team to experience, as well as for my sim team to experience, because sometimes sim can feel silly, and this was not silly. And so really it helped our education team, helped our nursing and leadership team, because it was so real.
Yeah. No, I imagine if when well done, that it sticks with you, and that's sort of the thing that helps the education, if you will, stick.
Yeah, it definitely stuck with them. I would say that everyone, we had 50 people through our simulation in 2 days, and it stuck with everyone, and they were very, very impressed with it as well.
Brian, what do you see as you go around the country doing this work with others, with hospitals and health systems? What kind of impacts surprise you?
Oh, that's a good question. I don't know that I would say it surprises me. I think we very often hear that there is some reluctance, and I think it's really important to as I mentioned, I think it's important to address that and think about that there will be some reluctance. This can be very uncomfortable, particularly if you haven't been in a simulation before. I think what we almost universally hear is the same kind of feedback that Holly just shared, that these type of simulations really stick with you, and people end up wanting more, and there's nothing, as you'll know if you ever there's nothing like converting someone who wasn't so sure, who you will now have a really strong champion in your organization for doing more of this.
Okay, thank you. Yeah, I imagine they end up being your biggest champions. Holly, how do you scale this work? How have you been scaling this work? So you started with, sort of your key folks, and you had a multidisciplinary team, and I'm sure, the ER is the first place you start this kind of thing, or, you is at least early up on the list. How did you move it across departments and continue to spread it across the team?
For nursing, we have, an annual skills lab, or what I call boot camp. And so for the nurses who weren't able to participate, we showed what we learned, and we talked about what we learned. For us, it would be really hard to duplicate what Laerdal did because of the high skill of their trainers. It would be very hard to do that. But we talked about what we learned, what we're weak at, because they identified what we're weak at in the organization. And so we talked about those learnings and practiced those skills that we could practice with our own expertise. And then across our other departments, we've just done a lot of reporting out and discussing it as well. And then we'll be planning, we have some more tech and things coming to Bingham, and we'll be planning some additional trainings within our own team at a smaller scale. but that's just one way that we're rolling it out.
Great. What do you recommend, Brian, as you start see, different departments? How often, how many, how fast does it move?
I don't think there is a really good answer to that, other than you got to start somewhere. In simulation, there's this general rule that you get, and I'd probably say that in adult learning in general, that there's the concept of low dose, high frequency. So sometimes you need to bunch the education together in 2 days, like we did when we did the in-person live training. But to the extent possible, try to spread this out and have many touch points, so that there is some so that people tend to forget pretty quickly what they learned in a training session. So getting back as often as possible. I don't know if that's once a quarter, if it's once a month. And also doing, breaking it down into smaller, like Holly described, focusing on some small subset of the simulation, rather than trying to pull it all off all at once.
I like the idea of creating opportunities to, whether it's not go through the full thing, but have some small conversations. Is there a conversation that happens at the professional governance meeting about what did we experience? Having opportunities to keep bringing it up and talking about what some of the opportunities are and where some of the learning has been, I think is a great idea. Holly, I'm going to pick on something that you had said that I know struck me in talking with some of our leaders who work particularly in security, that when they walk in, most caregivers, when we walk into a room, we are not making sure we know where the exits are. We're there to help the patient. So can you talk a little bit, Holly, about how you helped some of your team members, particularly those who are clinicians, think about that without feeling like they were losing the patient care aspect that they were coming with? Like, how did you help them integrate I need to keep myself safe so I can take care of that patient concept with them?
Yeah, I know we likened it to the AHA training of safety first for the responder. So just breaking that down to you have to be safe yourself. And really, we never want to walk into a de-escalation of someone and put our own self in jeopardy, regardless of what is occurring. And so they just really focused on aligning it like that, like you'd think of as a first responder, and just really giving, we'd set up a room, and we had a marked door. It wasn't in a small room, but it was a big room with a marked setting, basically. And it just being very careful if you entered the room that you didn't get into a spot where you could get cornered or something could be used against you, or that you were close enough to get grabbed, and those kind of things. Just thinking about that more and being careful that you always have someone with you, or 2 or 3 people with you. Like an extra person that might not be enough. So it was just really just learning that and talking it out loud and observing, because they videoed everything. And so being able to observe what had happened was really important too.
Hey, I know we're starting to get some questions in the chat. Brian, let me let you answer this one. I saw you lean forward, and then we'll get to those.
Sorry, I got this. My mind was going to, you wanted me to answer the question. So there is I think this makes sense to make sure everybody understands what exactly the simulation looks like. So we are using, our subject matter expert is also acting as the person that needs to be de-escalated. So the person who's agitated, and he can play whichever role you want. He can be a patient, a visitor, a family member, a colleague. But yes, it's a standardized, what we would call a standardized patient. It's not one of our simulators, for the simple reason that we need more dialogue, we need body language, we need tone of voice and stuff that we just can't do on a simulator. So you get that. And that's also why it's so impactful, and can be a little overwhelming if you're not careful about how to do this, because this is a real person who is acting like he's really angry. And so that's how we run them. So this is a person obviously who's very familiar with de-escalating in his everyday work, who's also delivers de-escalation training in a more didactic way. And so between that person and the RN, who's our clinical educators on site, they do all the observation of all those behaviors that we're looking for in the team doing the de-escalation, so that we can capture those as data points. I hope that makes sense.
No, I appreciate you addressing that. And Jason, I know we've got someone with their hand raised, so if you could encourage them to come off mute and let them ask their question directly. Kimberly, you can hopefully unmute and ask your question. Not sure. Oh. Well, hopefully you can type it in the chat. Apologies that it isn't working for you to unmute. I'm not sure why that's not functioning, but let me get to, we'll come back to you and hopefully you'll be off mute. We've got a couple of folks who would like to ask questions, so hopefully Jason and Chandler are figuring that out. I know we've gotten a couple of things. How do you, obviously, you're using simulation to drive this. How do you work with folks who have, they do de-escalation training, but don't have necessarily a sim lab on site?
Yes, and if I could just, sometimes we think simulation requires a lab and we're lucky that we have one that we can do, shoulder dystocia and those kind of advanced mannequin functions. But simulation can take place anywhere, really, you have a dedicated space, your camera, your objectives, your simulation written out. We do this a lot when we practice emergency operations, for example, like maybe we practice a code amber where a baby's been taken, and we would practice all of that. And it's not technically in a sim lab, but it's a set of people with certain roles practicing a simulation with, the hot wash afterwards to determine what went well and what didn't and what you need to improve on. And so thinking of it that way is really good. If you haven't ever done simulation before, you're probably going to need to have a facilitator or company assist you with that so that it's done well. When we first started doing simulation, there was somewhat, we had a lot of difficulty with participation because people were worried that it would be a gotcha moment where it would affect their evaluation, or people think they were dumb, or just different things. And so we had to have a lot of psychological safety, to Brian's discussion earlier, that this is just for us to learn. And we all have gaps in knowledge and practice, and we're here to just get better as a team.
Absolutely.
Can I add to that?
Sure. And
It's
then we'll
just
go
so
to
important.
you, Michelle.
It's so important, and we hear this constantly from our hospital customers, and we're trying to balance it because we also do a lot of business with nursing schools, but we hear a lot from our hospital customers that many of the new nurse graduates are a little bit traumatized by the way that simulation has been used in some nursing schools, where it's seen almost sometimes as punitive, and not so much as because they get graded. What we do when we are on site delivering simulations on behalf of hospitals is it's all about what can we learn as a team and as a system. We never after individual performance, because it's all about creating that safe space where we feel safe to make the mistakes that we don't want to make in front of patients or on our patients.
Absolutely. Yeah. Role playing can happen pretty much anywhere. You just need to set up the scenario and have the skills, I think, are more important than anything else. Michelle, let's go to your question. Thank you for being patient.
Oh, no problem. This is very interesting because I am in Louisiana, and we just got a sim lab. So I'm really excited about that. And we actually have a 30-bed psych unit, and we did simulation for our staff, and it was a de-escalation. Now the thing was, we were the voice of the man again. So our nursing supervisor was the voice of the ALS man. Of course, we couldn't the arms couldn't go up and down and things like that, but we kind of said, I'm punching you, and we had to act and de-escalate the situation and put him in restraints. But so what y'all did is y'all actually had someone sit in the bed and actually be the person, correct? The
We
actual
had
patient.
We ran this as we had our simulation was we had a ICU patient, a woman who'd come in from a car wreck, and her husband has arrived and doesn't know what's going on, and he has a lot of other emotional psychological issues that he
Mhm.
brings into his visit, and past traumas, etc. Him and his wife were fighting, like all these things are happening in his head.
Okay.
And so we had to figure out how to, emotionally de-escalate him so that we could, they teach you how to set the right boundaries, how not to say the danger words, how to truly de-escalate that situation so that really at the end of the day, you can let him see his wife. Like he gets to a place where he's able to do that and you are able to have that compassion towards him for that. It could go either way. I mean, he does have scissors and a stapler that's left. That was another learning we had is we had things in the waiting room that he could use as a weapon. So, really
Okay.
doing a walk around all your places and saying, could this be weaponized? Because we think about that in psych, we think about that in ER, but we don't necessarily think about that in the ICU waiting room. There could be something there that an upset person could use as a weapon.
Absolutely. And I know there's some on cloud scenarios. I've seen those. And that's in because I have that subscription. But just another quick question is, so the ancillary people, like the housekeepers and all that, they don't get that CPI training. Did you educate them before you did the simulation, or you just kind of like threw them in there and see
Yeah.
what happened? Okay.
Throw 'em in there,
That's
see what
interesting.
happened. We don't have a lot of housekeepers who speak English. And
Uh-huh. Okay.
so we do put every staff member through a simple Relias training as our learning management system on workplace violence and de-escalation. It's very short and we have different modules depending on where you work and your ability, whatever license you're at. And so we have some basics for every staff member and we have that in Spanish as well. So they're trained on those safeties. And then we just wanted to include them, great people, smart and kind people. We didn't want them to be afraid and then also the housekeepers have things within their cart that could be used as a weapon. So just being mindful that if they're near a situation that they wouldn't want to bring their cart close to that kind of thing.
Okay. Thank you. I appreciate it.
Very cool. It looks like we have another question coming in from Renee. So Jason, let me ask if you can unmute Renee so that she can ask her question as well. All right. Looks like you're off mute.
Yes. So, excuse me. As I put in the chat, I'm running a 48-bed inpatient psych unit. And this is one of the things that I recently brought up because I'm a new leader there. And I am trying to sell them on the idea of bringing in some other type of de-escalation technique, as well as bringing in other disciplines. So what Holly had mentioned about the housekeeper, I feel like a lot of disciplines that come on the unit, everybody should have that type of training. So I'm trying to sort of sell that, to my boss. And what advice do you have, Holly, for me to continue on that path?
I just invited them. We just took a swath of people and we asked housekeeping to send 5, engineering to send 5. We just tried to do a swath across the disciplines for that. And we've just had, I think, enough leadership support to do it. But, you could use wouldn't ever want a housekeeper to become someone's prisoner accidentally or be used or hurt by an inpatient. So just talking about it that way might be helpful as well. A lab tech, anything you would want to make sure that they had that self-awareness and that basic training and are an ally as well. It's kind of like hand washing, right? Like infection control is everybody's responsibility and workplace safety is everybody's responsibility. It's a very similar idea, regardless of what your licensure is.
Right.
Go back
Thank you.
to
Thank you.
Thank you, Renee. I appreciate the question. And when my husband left the small town, he grew up in and came here to Chicago for college, one of the orientation classes they had at the University of Chicago was understand you're in a city. And just doing a little bit of that, like, hey, here's some, common scenarios. Here's things that may happen to you. Here's how to be aware on the L and so forth. And I think there's a level of that I kind of wish everyone got some exposure to. These are things that could happen. I mean, you read about them in the news, and how do we make sure that everyone on the team has at least those basic skills? But Brian, let me turn to you and double click on this question a little bit more of, what is, when someone calls you and says, okay, we want to do this, what's your advice in terms of, how broad and how wide to go?
So we always try to get a sense of what are your objectives. So what are the key staff members you would like to get through, and then it's really mostly kind of a logistics conversation based on the number of people you want to get through. We can fit a certain number of people into one day, and the benefit of the Laerdal Accelerate program is that we really do everything for you. All you need to do really is to decide how many people you want to go through this training. If there are any special considerations, is there so for example, I think at Bingham we did this training in the education department, but we can also do this in your ICU if you want us to be there and have people yelling. It might not, but we can do it there. We can have the patient in the bed. We can do it in a waiting area. And then once we have all that figured out, it really becomes how much time do we need to be there on site. And then we fly in our educator and our tech, our subject matter expert, for other scenarios that require a simulator. We will also ship those in. So it really is kind of a simulation in a box to make it as easy on the hospital as possible. And for those of you who already know who your Laerdal rep is, I would give your local Laerdal rep a call. And if you don't, I think Chandler shared my email address in the chat, so more than happy to jump on a call with anyone to walk through options.
Absolutely. Yes. I was going to mention that if you'd like to talk to Brian more about this, his email is in the chat. Certainly we can connect you with him otherwise, but really helpful to hear sort of what some of the opportunities are here and some of the different ways you approached it. So let me ask you, Holly, what are a couple of things that have sort of surprised you about this work? And sort of, you went into it with a set of objectives, what you thought was going to happen. Are there things that have surprised you as you've moved through the process and trained your team?
I think what we were weak on surprised me. And then also the company also just walked through some of our work areas and gave us some feedback on safety and things that we were maybe blind to because we work here every day. And so there's just some things that we've got to improve our physical space, definitely. And we're an old hospital and we don't have all the fancy things. So just really using the opportunity to work with Laerdal to identify some other areas with their team was really important. And then, there's always these unintended consequences whenever you do anything. And one thing that we had to correct right away is we ended up having to put signs everywhere that there was a de-escalation training in progress. You're going to hear yelling, that kind of thing. Like that's something that we didn't necessarily think about. Like we'd put some signs close by, but we didn't realize that voices would carry. So that's always something to consider. Don't want to escalate the escalation. And we also involved, so you think your security team would be your best, but they weren't. They were our worst. And that was a really good learning. Obviously, the security team needs a lot more help because they kind of want to go to, let's tackle somebody first. And maybe that's just because we're in rural Idaho, so they think that way. But that was a big learning for us, is that the nurses were way better at de-escalation than the security team was. And the actual SIM leader, the guy from Memphis, said that that's not unusual. The hardest people he has to teach are those in law enforcement on how to de-escalate. And so that was a big learning for us. We have to spend a lot more time training our security team.
Yeah, I'm not surprised that there was so when they filmed the Chicago shows here, there was actually a a whole bunch of 911 reports for one of the scenes that they were shooting because there weren't signs far out enough to say, yes, we're simulating a plane crash on Wacker Drive and so forth. So it became quite an event because people thought this small plane had actually crashed as opposed to being a scene from a TV show. Brian, from your perspective, what are some of the things that surprise you? I mean, I'm not surprised that the security teams who have a set of tools that may not have started with de-escalation are challenged sometimes with engaging there. But what are some of the things that surprised you?
I'd give you one that surprises our subject matter expert, as we've talked about now a couple of times, for this particular simulation is a law enforcement officer. He is constantly surprised by how little attention we pay to our own safety in healthcare. And I'm not so surprised because, you go into healthcare because you want to help people, and that is our focus. But I think if we just pay a little bit more attention to the fact, we can only, you cannot help someone if you're knocked out yourself. So I think that I don't think we want to make safety the number one thing we think about at all times. And I don't think that's where we want to go. But I think just having a little bit more general awareness of, don't place yourself in an unsafe situation. Don't be the hero. Don't go into this yourself. Go ask for someone to back you up. And I think just a little bit more of that thinking could actually be a big help.
That's probably part of where half of the work that we do around well-being has come from, is that so many clinicians want to help others first and sometimes don't put that attention on themselves the way they might need to. All right.
Tell us on the airlines to put our oxygen masks on first before we help other people.
Exactly. We would be terrible at that. We'd be passing out. Let me ask my final question that I ask everyone I get a chance to interview about topics, which is, and I'll let whoever feels like jumping in first. What advice would you give to someone who wants to do this? Brian, beyond call me, I will help you set it up. But this is a thing nobody really wants to think about in terms of, nobody wants to put themselves in danger. Nobody wants to experience that feeling that someone is that angry or that upset, especially in a place that is about healing. So what advice do you give people to help them understand both the importance and then how to get started? So whichever one of you wants to jump in first.
I would say that nothing starts unless you try. And sometimes it's discouraging in leadership. Sometimes people will tell you no. And so you have to decide, well, how do I just start? Like, just small. How do I get one tiny simulation done with who reports to me? How can I just do one small thing? Something I did right out of the gate when I became the CNO is I went and visited a really nice simulation lab that's at one of our local universities. And I just learned so much. I learned so much about how they set up simulations, what equipment and people and skills and technical skills are required. And that was really helpful for me. So even that gave me at least an idea of, this is what this could be. What would that translate to what we can do or afford?
Brian.
I would say, again, start small, but also think about who might be able to help you. And they might already be in your own organization, and you don't know it. Do you have a sim lab? And if you do, is there something they're comfortable taking on? Do you have site units? If you do, you most likely have someone on one of those units who actually knows how to do this and can help you put something together for the entire staff. And also think creatively. I think we talked a little bit about how funding can be a challenge. So in addition to looking at grant funding, this might be something that your professional liability or your workers' comp carrier would be interested in working with you to at least co-sponsor. So think outside the box.
And also reach out to your local law enforcement and see if they have a trainer that they would lend you. A lot of times they've done some, gun violence training with us and how to deal with active shooter and different things with the local law enforcement, and usually happy to collaborate with you.
All right. Holly, Brian, thank you so much for sharing your experience. I heard some really important advice here throughout the call, but at the end, especially, start small, start somewhere. And the fact that this is essential work and will help do something that as caregivers, we may not be that good, which is to protect ourselves. And even if we are just taking a little percentage of that time to focus on protecting ourselves. I certainly heard that this does not happen without psychological safety. So if that's a concern or maybe a deficit somewhere in the organization, start there. Really address that and make sure you have a psychologically safe space in which to do this work. And the last thing, which I really want to double click on, which is not only to have a plan about how you're going to eventually move this across the organization, but to look for partners. You don't have to do this by yourself. Whether it's bringing in Brian to help the team, whether it's your local law enforcement, whether if you are an organization that has psychiatric teams at your organization. This is, as I mentioned at the beginning, something that has grown up in behavioral health, and they can help you find the right resources. So with that, I'm going to wrap us up. Again, Brian, Holly, thank you so much for sharing all of your thoughts and opportunities. And we will be making available a recording of this, which Chandler just put in the chat. Encourage you to visit the AHA's Hospitals Against Violence page, which she also just put in the chat. For additional resources, we are actually working on some resources related to de-escalation and how to start building that plan, of which simulation can be a part. So for anyone, any further questions, doesn't look like we have any in the chat. Really looking forward to continuing this conversation with Laerdal and with the team. Thank you so much, and we're adjourned.
All right, thank you.
Thank you.